effect for the letters. And I am from Kerala, Trivandrum. The coconut trees, background you see the coconut trees, and one of the beautiful beaches we have there. What are we doing? That sentence is merging with the background blue color and very difficult to read, because honestly we are not doing much, which is true. And rehabilitate is a very important thing, and not just precisely defined. There are a lot of things we have to do. As I put there, that the word rehabilitate is also merging with the background green color of the coconut trees also. And the question is, what are we doing to rehabilitate our own rheumatology sufferers? That is not about the studies which are published studies, unpublished studies, and to be published studies like that, no. Our own rheumatology sufferers. And please note, when I wrote sufferers, the F and the R, the number of F is more for F and for R, to emphasize, is a real suffering. Even though generally people say, however much severe the vomiting is, the vomiting contains only 1 T. There is a classical statement, but when you say suffering is a real suffering, only the sufferers know, and the sufferers' relatives know how severe the suffering is. So that is the question we have to address. What we are doing to rehabilitate? And the honest answer is that most of us are not doing anything really worth mentioning. That will be the honest answer. I said most of us. I did not say all of us. Most of us. This one. Most of us are not doing anything really worth mentioning. But rare exceptions are there. For example, this forenoon, I had the good fortune to visit our Dr. Chandrasekharas and Dr. Sarmananda's institute, where I see that they have a well-arranged, well-established rehabilitation related services. So, rare exceptions are there. We should congratulate them, we should learn from them, and we should bless them. So we could say there are certain emerging centers of excellence, like a silver lining in the cloud. Otherwise, honestly speaking, it is true, most of us are not doing much. So let us have a closer look at this challenge. This challenge means the challenge of rehabilitation of our rheumatology sufferers. So that is our topic, that's what we want to discuss. Now 5 points only I want to present before this August group. Just 5 points only. Now why I say 5 points only is because ESNL, again a burning issue. What is ESNL? This is ESNL. Enlarged stomach noontime lecture. And an ESNL, even if it is done by Shakespeare's Mark Antony himself, is a real challenge. When our stomach is full, we want to be horizontal if possible. If we cannot be horizontal, at least semi-horizontal or vertical, but still we want to sleep and not listen to anybody speaking about any topic at all, leave alone about this rehabilitation or suffering or whatever it is like that. So therefore, even if Shakespeare's Mark Antony himself is giving a lecture, problem is that after the first 5 minutes, the most important thought process passing through your mind and my mind also, if I am sitting there and listening to somebody giving the ESNL, is when this fellow is going to stop. And most often, unless we do a mind biopsy, we have no idea when the fellow is going to stop. That is why I am saying 5 points only. So when I come to the fourth point, it is very clear, he has got only one more point and he is going to stop. And the fifth point, that is the last point, and the fellow is going to stop, no problem. So that's why I say 5 points only, very clearly. The 5 points only. So these 5 points only, and these 5 points are, my first point is thanks. Second point is what are we doing now? Third point is what we should be really doing. Fourth will be what all we can do. And the fifth and most important will be let us share our views and experience about this. Let us share our views and experience. So these are the 5 points we should discuss. So first point is thanks. When I say thanks, it is not just a thanks in small letters like this. What I mean is, so I cut off that. What I mean is real, solid capital letter thanks. Because I consider this a great honor and a special privilege to address the distinguished doctors of the Garden City of India. The Garden City of India, which is slowly becoming the Silicon Valley of India. So it is a great privilege for me. That is why I say thanks not in small letters but thanks in capital letters. So that is my first point. And special thanks to Chandrasekhara. So I will just come down and shake hands with him for giving me this great honor and thanks. Thank you. God bless you. So 1 point is over. Now comes the second point. What are we doing now? That is Julius Caesar, whose famous words, Vini, Vidi, Vici. I came, I saw, I conquered. Likewise to my rheumatology patients also I say, not I came, they came to me. I saw, and not I conquered, but I prescribed. So I will say they came, I saw, I prescribed. That is all. I just prescribed some drugs and said, okay, go away, get healed or get cured or whatever it is. Like that, there ends. Now I may also say, okay, do some exercise. I may also say, you go to a physiotherapist and get some physiotherapy done. That is all. And what the patient does, usually I am not bothered or I don't spend time on that. And they do in their own way. And what do they do? Our patients also are confused. They don't know which way to go. Why? Because they have so many places to go. So many padis are there. Ayurveda, allopathy, homeopathy, naturopathy, and all sorts of things are there. Magnetotherapy, all sorts of things are there. They don't know where to go. So what happens is, unfortunately, in this confusion where to go, and in our socio-cultural menu, generally there is a belief for rheumatic diseases, modern medicine has nothing to do, nothing to offer except giving some painkillers only. So here in this picture, there is a practitioner of modern medicine. One patient is there. But there is a long queue in the opposite direction to a practitioner of one of the alternate systems of medicine. And the proverb says, a rolling stone will not gather any moss. Like this, unfortunately, our patients also will be rolling from doctor to doctor, Vaidyan to Vaidyan, hospital to hospital, institution to institution. And as the rolling process starts, as in the top left corner, beautiful God-given hands, but rolling from doctor to doctor, institution to institution, finally you get the crippled hands, deformed hands with all the deformities and all the suffering. In fact, actually we are all partly at least responsible for this rolling process. During rounds, the boss is asking the assistant, for 32 days, we are investigating this patient. So far, there is no diagnosis, and what do you suggest? Promptly came the reply, there is a discharge him, sir. Not only discharge him, sir, let us send him to the other unit's OP. And when we send him to the other unit's OP, we should not write anything, nothing in the writing, but just verbally only you say you go to the other unit. So, our message should be, let us not discharge him, sir, let us give him hope and care and happiness. So, our weapons against inflammation and arthritis, if you look, good old weapons, good old drugs we do have. Recently emerging drugs we have. We also have the ones which are newly emerging, like the chicks coming out of the eggs. And that is famous Bernard Shaw's play, Doctor's Dilemma. And because of all these drugs, we also have the dilemma, good old drugs shall we give? Or the most recent latest introductions shall we give? So this confusion goes on. So unfortunately what happens is, in this confusion we give a lot of drugs we prescribe. And our management of the rheumatology patient suffering usually ends with, or predominantly ends with, this stage, prescribing 1, 2 or multiple drugs. Maybe the old one, maybe the new one, maybe a combination of both. That is all. So what we should be really doing, that is the next point, third point. See, there is a WHO website where International Classification of Functioning, Disability and Health, ICF, detailed classification on disability as impairment, disability and handicap. So our patients, impairment certainly is there. If possible, we have to help them go back to normal. But disability, if possible, we should minimize, and handicap, if at all possible, we have to really prevent the person deteriorating into the stage of handicap. True. A few inspiring stories of great rehabilitation. In this context, worth remembering. Inspiring stories of great rehabilitation. Lance Armstrong. Extensive malignancy, disseminated malignancy, repeated surgery, repeated chemo, real Superman after the accident, because Christopher Reeve Foundation is today the world's largest funding agency for research of the spinally injured and rehabilitation that way. 2 beautiful autobiography books by Christopher Reeves, Nothing is Impossible and Still Me. Stephen Hopkins, extensive advanced motor neuron disease. Practically all the muscles are paralyzed, but still writing international bestsellers like A Brief History of Time. And speaking of rheumatological diseases with rehabilitation, famous painter, Rubens, painting of gout, another beautiful painting, famous painting by Rubens, The Consequences of Our. Thomas Sydenham, a sufferer of gout, and the autobiographic description of an acute attack of gout by Thomas Sydenham, in spite of the repeated suffering by gout, is something that has not been surpassed so far till date. He writes about an acute attack of gout. I went to sleep hoping it will be just like any other night. Early dawn, I was awakened by an intense, excruciating, agonizing pain in my left instep. Now it is a gnawing pain, now it is a throbbing pain, now it is a tearing pain. Now I was feeling 1,000 devils were pulling my body in different directions. An involuntary shudder used to pass up my spine and down my spine at the jar of a door being opened or a window being closed, or at the sight of a mosquito or a fly flying in the farthest corner of the room for fear it might alight on my inflamed toe. Quotation closed. So there is a beautiful autobiographical description of Thomas Sydenham in spite of repeated attacks of gout. King Henry VIII, repeated attacks of gout, severe gouty arthritis, still did all the mischiefs and married 7 times. Isaac Newton, another victim of gout. Benjamin Franklin, Thomas Jefferson. Famous painter Renoir, he wrote, "The pain passes but the beauty remains." Rehabilitation after severe rheumatoid arthritis. One of his most famous painting, The Bathers. Another beautiful one, famous one of his paintings. Last stages he could paint with the brush held in the mouth only because the hands were so deformed. But still, whether he rehabilitated himself or his doctors rehabilitated him, we don't know. And if you just give the name Renoir, see how many references, 6 lakhs and odd references about him. Another famous painter, his famous painting, severe rheumatoid arthritis. The first cardiac transplant surgeon, Christian Barnard, had severe rheumatoid arthritis, and even in this picture, the metatarsophalangeal joints swollen that we could appreciate. So in spite of the deformity induced by pain induced by rheumatoid arthritis only, he could do the first cardiac transplantation. And see how many references about Christian Barnard. And that is the first photograph of the first cardiac transplant surgery of Christian Barnard. And the other way around, rehabilitated himself in spite of SLE, not for good but for autocratic, murdering so many people, killing so many people, and then occupying for himself in history a dark name only. The Philippine president. Those butterflies are flying all over. I just put it to emphasize that his problem was systemic lupus, SLE. So these are all inspiring stories of great rehabilitation. So I am sure that you and I will not be able to put our patients back to such great heights of glory and effective functioning, no. But at least a pain-free life or a reasonably tolerable life or productive life, well, that may be what we can achieve. So measures beyond drugs are important. Proper positioning to prevent contractures and deformities, very important. And a very common is a pillogenic contractures. What I call as pillogenic contractures is during the acute stage, patients keep pillow at the popliteal fossa, bend of the knee, and pillow to support the back. And because they lie on the pillow like that, they develop a lot of contractures. Graded exercises, splinting, assistive devices, very important like that. Fourth point, what all we can do. Let us use the acronym personalized care to summarize what all things we can do. After all, rehabilitation attempt has to be personalized. We cannot generalize. Personalized care is important. So I'll just summarize what we can do by using the acronym personalized, each letter representing one important thing. P for positioning and physical modalities. Positioning of the patient during the acute stage so that deformities can be minimized, maximum comfort can be given, and physical modalities including heat in various forms, cold, vibration, ultrasonics. E for exercises and equipments assisted health. Exercises is something that we tell the patient, okay, exercise is required, and patients do different types of exercise, and physiotherapists also do different types of exercise, and many a time, unfortunately, exercises, unless properly and individualized manner it is prescribed for the different joints, it may be counterproductive because it may aggravate the deformity, it may lead on to deformities, it may create further damage to a joint, and aggravate the pain. So exercises has to be given properly, both active exercises and passive exercises, both against resistance and weight and also without resistance and weight, and has to be done properly by a specially trained and a specially motivated person taking time. Usually what happens is somebody goes and then just moves like that. The elbow is moved, hand is moved, the knee is moved, patient will be howling and crying, but the physiotherapist doesn't leave and goes on doing physiotherapy. It becomes something like a battle of wits between the physiotherapist and the patient. Anyway, R, rest and relaxation and stress management. Very important. And Dr. Chandrasekhar had extensive experience in a research project on the effect of yoga and relaxation on rheumatoid arthritis. And he has completed it and you have sent it for publication. So maybe at the end of my talk you can just add a few words on the importance of stress management and relaxation in the total rehabilitation of the rheumatology sufferer. S, for splinting and stretching. Very important in preventing deformities. O, for occupational adjustments. N, for negative fighting. Why I say negative fighting is, regarding rheumatology patients, there are a lot of negative concepts, negative ideas and negative prejudices. We ourselves know, we remember the answers we wrote during the MBBS days. Suppose a question is on rheumatoid arthritis. We start our answers like this: the etiology is not known, therefore the treatment is only symptomatic. In other words, there is a feeling of helplessness, sadness and pessimism. And this sort of negative feeling concept is there for doctors also, for most of the people like that. Then A, for assistive devices. Various types of assistive devices. L, for locomotor help. Because patients confined because of deformity, because of pain, confined home, not going outside, getting depressed and getting contractures and getting lot of problems. So locomotion, helping in movement, going out, very important. Incidental illnesses are important. Treating and managing, diagnosing, treating incidental illnesses and complicating illnesses. Yes, for surgical interventions whenever required. For correcting deformity, surgical interventions we can do. E, for education. And education is extremely important, particularly in the present socio-cultural milieu. And D, divine blessing. Because without divine blessing, nothing is possible. Whatever we do, in spite of all that we do, Almighty God has to bless us and bless the patient and the patient's relatives for getting a satisfactory improvement. Because in the present socio-cultural milieu, we are all practicing philosophy of defensive medicine. And when you are examining a patient, we are asking ourselves, is this bloody fellow planning to go to the High Court or to the Consumer Court? Every patient is a potential litigant and troublemaker unless proved otherwise. That's the philosophy of defensive medicine. See, first visit, doctor and the patient. Patient has got a plaster. Second visit, doctor is going to examine the patient. The relative is coming. Relative is a muscle builder, six-pack muscle and all. And the relative is asking, why didn't you do a total body MRI scan? And then the relative is saying, I had taught that doctor a lesson. So what happened? Third visit, patient has got only one plaster. The doctor has got multiple plasters and doctor has got crutches also. That's a philosophy of defensive medicine. So the bystanders who are doing weightlifting, who are doing an organ specific percussion of the doctor, and also litigation. Particularly if the patient's kids are abroad, better be extra careful. Really common is a syndrome called idiot syndrome. Idiot syndrome is this: internet downloaded information overload, thick skin and systemic enterobiasis. enterobiasis is a pinworm infection. The local variety we know, systemic variety. That is a systemic enterobiasis. Internet downloaded, information overload, in thick skin, and see, this is an example. I am examining the patient, and those people are doing the internet search, and they are saying granddad's dog is surely out of date. See the situation? One doctor is examining the old man, and the family has come from abroad. The kid is not at all interested, looking in the opposite direction, sitting and reading some pornographic literature only. And he is saying, "Doc, why don't you try etanercept or infliximab for my dad?" These fellows are not going to buy even aspirin for the dad. But they are asking, "Doc, why don't you try etanercept or infliximab for my dad?" And the wife character is asking, "Hey, do you know how costly these are really?" Then he is saying, "Don't worry dear, these Indian doctors might not have heard about these names at all." And the kid is asking, "Mom, in India, how long old men live?" And mom is telling, "This dog seems to be keeping him alive, idiot." And related to that is the syndrome called CID syndrome, cephalomegalic intentional dysarthria syndrome. Cephalomegaly means head weight. Dysarthria is dysarthria. Intentional is intentional. Very common. When I am sitting in the OP, in my consultation room, suddenly you find that somebody is knocking and saying, "Good morning, Dr. Philip. I am very sorry to intrude upon your clinic," like that. See, the poor fellow has been speaking normally. 1 year he has been living abroad. That is why he is speaking like that. That is called cephalomegalic intentional dysarthria. The chairman's permission, I will tell you an example of a cephalomegalic intentional dysarthria syndrome of one of my own classmates, batchmates. See, when I was in my office, as head of the Department of Medicine in Trivandrum Medical College, in the afternoon I had a postgraduate discussion program. So I was making some slides in the laptop in my room. So suddenly the half door is open, but somebody was knocking. I just looked up and found that somebody is in shorts. In the hospital only, somebody is in shorts like that. And he is saying, "Oh, Joy, I am very happy to know that you are the attorney now. It seems you are busy. You are doing something on the laptop like that." "What are you doing?" Yeah, but I said, "See, I got a class in the afternoon." "Oh, you mean you are busy. So what time you are likely to be free?" I said, "In about 2 hours." "Okay, I will go around and meet our other batchmates and come back." So he has been my own batchmates in the previous days like that. And I was telling myself, poor fellow, he has been talking normally. I don't know what happened to him like that. So what happened is, after 2 hours, after the class, I just came back, I was sitting. Then this fellow is coming and saying, നമുക്ക് പോയി ICH പോയി ചായകളൊക്കെ കുടിച്ചോളയാം. See, that means talking in simple colloquial Malayalam. You know what happened? After talking to me, he went and spoke like this with the CID, cephalomegalic intentional dysarthria, to our other batchmates. They were not as tolerant as me. So they spoke into his ear all unprintable words, all unprintable words, all synonyms and the opposite, everything like that. With the result, the dysarthria completely disappeared. And he became normal, absolutely normal. So that is the CID syndrome, cephalomegalic intentional dysarthria. So therefore, let us share our views and experience. That will be the last one. So when I say thank you, let me wish all the best and all success in your personal, educational and professional phases of life. And let me present a rheumatological thanks from each of the layers of the joints like that, one by one. Thank you very much. All the best.